Vishwajit Goyal sir, Dr. Orijit Chatterjee sir, and Dr. Shukumar Deparva sir. May I please call
stream হয় এখানে চাচোন এটা মই শেয়ার কৰিছো গ্ৰুপত
Okay. I'll take over from here. Okay. Anyway, yes, participants here. It's okay now. We are happy with the participants in the morning. Anyway, good morning to everyone. This is an instructional course. So it does not matter how many people they have, but thanks for coming and joining the instructional course. I'm about to start the course, but we are happy that we have a Gaurav. Actually, I don't know. Initially, I have asked the people of that for this course to him, but he's about to leave today early. But somehow he hasn't taken it, right? So why don't take a chance from Gaurav? We also can learn from him. So I invite here Gaurav, please take his place and please ask.
So warm welcome to all of you. So without wasting any further time, we are already 15 minutes late now. So we'll just start off with how to read a CT scan of the nose and paranasal sinus. I'll try to make it as simple as possible, and whatever I'm speaking here will all be evidence based. Okay. So basically, what is the role of a CT scan? So for us as rhinologists or ENT surgeons, a CT scan is like a Google Maps. So it tells you where to go, where not to go, what are the dangers that you're going to face during your surgery, and how you can avoid them as well. So there is a complementary function between CT and MRI. We all know that CT is mainly used for anatomy of the bones, whereas MRI is more involved in giving us soft tissue anatomy, like nerves, muscles, brain, etc. So both of them are quite important, and we use them. So there's a small video that I want to show you of one of the hospitals where you can see one of them seems to be like an ENT surgeon with a headlight. And they asked their senior professor after seeing an X-ray, mediastinal mass, which turns out to be something else. So then they take the patient up for surgery, and once they finish surgery, and then they come back, they are frustrated because they didn't find anything in the mediastinum. But then the senior doctor is like, look, the mass is not there on the X-ray also now. So one important thing that you need to understand is we don't operate on scans. We operate on patients. So you can never replace a good examination with a scan. That is the most important thing that you need to understand. So whenever you are given a reference in the ward, don't ask for a CT scan before you see the patient. So how do you ensure? So all this information that we have, CT scan, all these fancy things which we have, but still we are having complications in sinus surgery. So what is the problem that we are facing? Because we don't have the assimilation of this data in a proper manner. So this is a proforma that I use for my practice, where every sinus surgery has to go through this proforma. And if you see, the first thing that we always check is history taking, and then examination, SNOT 22, diagnostic endoscopy, and then comes CT evaluation. Even for CT evaluation, I have a very detailed proforma that my residents have to fill in. Unless they fill this, then they are not allowed to operate on the case. This is a guide to sort of explain what they should be looking for on the scan. And how did I get this idea? I got this idea after I wrote this chapter on complications in sinus surgery, because I realized that whatever information we have, we need to prevent the complication, we already have it even before we start the surgery. It's just that the data assimilation is not happening properly. That is the reason why we created this. Before we jump into CT, you just need to know about the windowing. You have the bone window, soft tissue window. So just understand metal is the heaviest thing that you'll see or the brightest you'll see on a CT scan, and air is the least dense. So you'll see it as black in color on a CT scan. So in between air and metal, you have fat, fluid, soft tissue and bone. Okay. So mostly we use soft tissue windows for organs like liver, lung, brain, orbit, etc. So for lung we cannot definitely use a soft tissue window. The reason being that the lung is again filled with air, so you will see it quite black in color. So there is a separate module that is used for the lung. Whereas a bone window is used to study bone detail. So for us, CT scan we use mainly a bone window to study anatomy. And if you want to see the extent of disease, then we ask for a soft tissue window. Like especially in a case like AFRS, then we ask for a soft tissue window. So one of the important films that you will see before you start reading a CT scan is called as the scout film. Scout film basically tells you which part of the body has been scanned, what are the number of cuts that have been taken, and what is the slice thickness that has been taken. Now this is a very, very important thing to study the scout film. Now what I am telling you is a real life scenario where one of the doctors in the US was actually, a case was filed against him. So there was a 52-year-old man who fell off a bar stool and he injured his neck. So he went to the emergency room and neurologically he was found to be intact at that point of time. And a CT scan was done. The patient has already had a history of ankylosing spondylitis, but multiplanar reconstruction was not done by the radiologist. So he reported as a distortion from position of the patient's neck and no evidence of fracture or dislocation. Okay, and he was sent off with pain medication by the ER specialist. And about a week later, first he had paresthesia in the forearm and hands, and then he developed weakness in both the arms. Then again he came back to the ER because he developed weakness in both arms. That time a second CT scan was performed, and this time they did a sagittal reconstruction. And when they did a sagittal reconstruction, this is what was seen. Can you see here? So there is a complete fracture dislocation of the C4, C5 vertebra. Eventually, patient had paresthesia in both hands and he had even residual weakness even after stabilizing this spine. So there was a penalty which was charged to the radiologist and the emergency medicine guy, $600,000, which is a very, very big amount. So if you look very closely, in the scout film, you can see that there is a fracture dislocation. But because they did not do a sagittal a reconstruction, multiplanar reconstruction, they did not pick it up. So even a scout film can actually save you from a lot of problems. So now coming to the scan per se. So whenever you ask for a CT scan, always mention nose and paranasal sinuses. Don't ask only for PNS. Because a lot of the times the problem could be in the internal or external nasal valves, and that could be the reason why the patient has got breathing difficulty. So like in this case, you can see the internal and external nasal valves very clearly. This is the internal nasal valve in this area, and the external nasal valve is actually between the upper and lower lateral cartilages. So any discrepancy here, you should be able to pick up. Normally, if the internal nasal valve diameter is less than 0.47 centimeter square, and it can be calculated on a CT scan also. If it is less than that, the chance of it contributing to the patient's breathing difficulty is going to be much higher. Okay, so there are definitive criteria to define what a narrow internal nasal valve is or not. So in the next part, if you go, you start to see the anterior table of the frontal sinus with the appearance of a single frontal sinus, which we are able to see. You can see the levator palpebrae superioris muscle there. You can see the frontonasal beak or the nasion, what we call, has started to appear. Number 4 is nasal bone. Number 5 is the perpendicular plate. You can start to see the cartilaginous septum, that is the anterior nasal spine, and the premaxilla. Okay. Now, how do we know this is the anterior nasal spine? If you study the maxilla, okay, there are multiple processes. You have the alveolar process which holds the teeth, you have the zygomatic process, you have the frontal process, and then you have the maxillary sinus per se. Okay. The anterior most part of this, anterior to the alveolar process, is actually the anterior nasal spine. And how you identify it is that if the part is seen along with the central and lateral incisors, it is the anternasal spine. Whereas if you start going behind, you will not see these incisors. This is called as premaxilla. Okay. Now, as we go behind, in the next cut, you are starting to see the intersinus septum, which has started to appear. Okay. The inferior turbinate is seen on the left side. You can start to see now the part of the maxillary crest has started to appear there. Okay. So, how do we know this is maxillary crest? Adjoining that area, you will start to see that there are no teeth, but you will start to see the palatine process there. Okay. You can also see a canal here. So, this is basically the canal for the anterior and middle superior alveolar nerves. So, whenever you do a septoplasty, if you have actually gouged out the maxillary crest, you will see that the patient will complain of numbness of teeth, and that is because of this canal. Because whenever you gouge the maxillary crest or anterior nasal spine, you are putting pressure on these nerves. Usually, it will actually improve. Unless you have damaged it, it will of course not improve. But otherwise, usually this numbness improves over a period of time. So here you can see there is an incomplete septation that has happened here. Now I want you to carefully see this video. So this surgeon, what he is doing is, there is a blind usage of debrider that has happened. Surgeon is probing medially, and what are we seeing here? CSF leak. Okay. So you can see the pulsation of the brain. Okay. Now all this, is this a excusable complication or an inexcusable complication? It is a complication of FES, right? We would have explained this to the surgeon, to the patient beforehand. But in this particular case, this is a non-excusable complication. You know why? Because the surgeon has not studied the CT scan before surgery. This patient actually had frontal sinus aplasia. He did not have a frontal sinus at all. So what might seem to you, on my checklist, we even have something called as frontal sinus presence or absence. It might sound very stupid to a person, but frontal sinus is not always present in every patient because it develops after the age of 9 years. And we all know that pneumatization of the sinus depends on your sinus health before the age of 9 years actually. Why? Because if you don't have enough air going through, let us say you have allergic rhinitis patients with very big adenoids in childhood, they are not going to have very good airflow in the nose, so they resort to mouth breathing. So pneumatization is not going to happen because you are not breathing through the nose. So where will pneumatization happen? It will happen. So in this case, if the surgeon would have studied this, CT, they could have avoided a CT scan. So this amounts to gross negligence, and there is no court which will deny the patient truckloads of money for this case. Okay. Next, I want you to pay attention here. This arrow mark that you're seeing is basically a supracochlear nerve and vessels. Whenever we put an eyebrow incision, we are supposed to spare this. Look at the curve of the frontal process of maxilla. Here you can see above the maxillary sinus, you see the curve. Just pay attention, later on you will see why. You can start to see a dipping that is happening in this area. If you pay close attention here, you can see some amount of dipping. This is the area where the lacrimal sac will start to house itself, and which will eventually become the NLD there. So here, if you observe, you can start to see a cell which has started to appear. This is the anterior most ethmoidal air cell, which is called as the agar nasi. Okay, so there is a big difference between agar nasi and bulla ethmoidalis. Agar nasi is the anterior most ethmoidal air cell, and bulla ethmoidalis is the most constant ethmoidal air cell. It is not always necessary that a patient should have an aggranacy, but it is definitely possible that a patient will almost always have a bulla epidermis. Even in the worst cases of sinus, where you have a patient who has cystic fibrosis, where they have very small sinuses, also bulla epidermis will be present. So what is an aggranacy? Aggranacy is nothing but pneumatization of the anteethmoidal air cell into the lacrimal pole or the frontal process of maxilla. So that is basically aggranacy. Now, if you look at the boundaries of the frontonasal drainage pathway, anteriorly you have the posterior wall of the aggranacy, posteriorly you have the anterior wall of bulla epidermis, and medially you have the middle turbinate, and laterally you have the lamina papillaceae. So if you have started to see the aggranacy, you are going to trace this a couple of scans posterior. You should start seeing the frontonasal drainage pathway. Now, to understand that, this is called as a frontal T sign, where the horizontal arm of the T is formed by the frontonasal beak and the vertical arm is formed by the perpendicular plate. Now, if you just keep following this, you will see at one point there will be a breakage in the frontal T, which means that there is opening of the frontal sinus. The other thing that I want you to start paying attention is, see, I told you there is a grooving which is happening in this bone, which is basically the housing for the lacrimal sac. Pay attention to the level of the maxillary sinus floor. It is above the level of the nasal floor here anteriorly. Okay. And now you start to see that it is opening into the aggranacy here. There is breaking of this frontal T, which is, you can see, the frontonasal drainage pathway has started to appear. Now this sac is starting to become a tube. You will start to see this tube here. I show you in very good detail. And you can also start to see the appearance of the middle turbinate. Always remember that the aggranacy is anterior to the middle turbinate. So you will not see the middle turbinate before seeing the aggranacy, unless it's an extremely small aggranacy, in which case it might not be very well pneumatized, so it can appear behind the middle turbinate also. But in majority of the cases, it is before the middle turbinate that you will see the aggranacy. Okay, so again, for us to understand, if you divide this orbit into multiple compartments, you will see that whenever the disease is actually in the medial compartment of this orbit up to this area, it is quite easy for you to address these pathologies through the transfrontal route. That is, you can do a frontal sinusotomy and you should be able to address this. But if you want to go beyond this segment here, beyond this red marker, then you will have to do an extended procedure like a frontal sinus drill out, like a draft 2B, or you might have to go cross-code where you do a superior septectomy and from the opposite side you have to go, or you might have to do a orbital transposition like what I showed you in yesterday's talk, or you might have to do a trephining. So one of these four procedures you will have to do if you want to go beyond the medial 1/3 quadrant of the orbit corresponding area, if you have to go far lateral. So that is also one of the ways for you to figure out before surgery itself whether I need to do this or not. Majority of the times what happens, people think, okay, let me first do sinusotomy and let me try going this, that. It's very clear, you will not be able to go. So you, right off the bat, instead of wasting your time, you can just start away with an outside in, drill out and then go in, that's it. So you will save a lot of time if you know how to read the scan. So there have been studies which have been done. This is a wonderful paper written by P.J. Borman, where they gave a lot of surgeons only the axial scans first, and they asked them to create a plan of how they would address this pathology. About 55% of these patients, the surgeons, they changed the plan by more than 70%. Like the plan was deviated by more than 70% once they were given the sagittal scan of the same patient. But they were not told that it's the same patient. So they were blinded. So they thought it's a different patient and they gave a totally different plan after seeing the sagittal scan. So whenever you want to study the frontal sinus, always make it a point that you have these sagittal scans with you, because you can see all the cells in one single field. That makes your life a lot easier, and I'll show you how. So yesterday in my lecture, I've already discussed about the International Frontal Sinus Anatomy Classification. So if it's okay with all of you, I'll just skip this part to save time. Okay, so we just have three groups of cells, anterior, posterior and medial. So you have agar cell, supra-agar frontal cell, interfrontal septal cell, and supra-orbital cell. So these things we will just skip. So one important thing you have to know is that whenever there is a supraorbital ethmoidal cell, so what is a supraorbital ethmoidal cell? It is nothing but pneumatization of the ethmoidal cells into the orbital plate of the frontal bone, which is basically this bone. Okay? So when you start pneumatizing and going above the orbit, then that is called as a supraorbital ethmoidal cell. In 100% of the cases, whenever there is a supraorbital ethmoidal cell, always, as a thumb rule, the anterethmoid artery will be in a mesentery. Okay, and this has been proven in hundreds of papers. It is not one paper. Multiple papers have proven this, that whenever there is a supraorbital ethmoidal cell, the anterior ethmoid artery almost always will be in a mesentery. So that is something that you have to pay attention to. Okay. So there have been documentation of supraorbital ethmoidal cells which are going as far lateral as the zygoma also. So be very careful when you are dealing with supraorbital ethmoidal cell. Especially if you develop a tumor in such a cell, it will make life very miserable for you. You have to do a very extended approach. The other thing I showed you yesterday is the intersinus septal cell. So one thing that you also need to pay attention to whenever you are dealing with pathology inside of the frontal sinus, not at the frontal recess. So the recess is this area. This area below the opening of the frontonasal beak is called as the recess. But when you cross this frontonasal beak, you are inside the frontal sinus. So whenever you want to do any kind of work inside the frontal sinus, then one thing you need to know is the ethmofrontal angle. Ethmofrontal angle, the more obtuse it is. Matlab, if this ethmofrontal angle is more like this, then it is more difficult for you to enter into the frontal sinus. So in such cases, what you need to do, you need to drill out this bore so that you can go along the anterior wall and enter into the frontal sinus. But if the ethmofrontal angle is more acute, matlab, instead of being like this, if it is like this, then your life is more easier. But this only matters if you want to work inside the frontal sinus and not in the frontal recess. Both are two different things. Okay? So this I showed yesterday, frontal osteoma. We have 3 grades, and normally we need to do a extended procedure like a drill out because you have to remove the tumor entirely. So you can see we've done a nice drill out here, and that is the frontal osteoma there. And very easily it comes out usually. It's not a very difficult tumor to deal with. Again, there are 3 grades that we have, grade 1, 2, 3. 1 where there is no obstruction to the sinus outflow tract. Grade 2 is when there is partial obstruction, and grade 3 is when there is complete obstruction of the frontal sinus. So grade 2 with symptoms and grade 3 without symptoms also you have to operate in frontal osteoma. And this is what the sinus will look about a year later if you done a nice drill out sparing mucosa. Okay. Now coming back to our scan, you can see the appearance of the middle turbinate here. This is a very crucial thing for us to know, because this middle turbinate, as you keep going posteriorly, you will start seeing that it attaches to the cribriform. At the junction between the vertical and lateral lamella, you will see the attachment of the cribriform. Now pay close attention here. You can see there is an elongated structure in the right maxillary sinus and a dot in the left maxillary sinus. This is basically the appearance of the infraorbital nerve. Now the infraorbital nerve always supplies this part of the cheek. That is why whenever you do a frontal sinus trephine, maxillary sinus trephine by using a trocar. I think yesterday Nitishore and I were having this discussion. There is a very high chance that you will damage some fibers of this infraorbital nerve which are supplying. Because if you look at the scan here, after coming through the foramen, it will actually go down. It will also supply the teeth lateral to the lateral incisors. Okay, and also this cheek. So whenever we do a frontal trephine, the chance of us injuring this nerve is on the higher side. And if you are planning to do it, by all means you can explain to the patient that this is the need for the procedure. But you have to explain it before the surgery, not after the surgery. So you have to have planning beforehand. Or just do a prelacrimal approach. You can spare yourself of all this. You can access the entire maxillary sinus, clear the disease and come out. Now look here, you can see beautifully that the entire nasolacrimal duct is appearing here so nicely. And if you pay close attention, you will see the duct is not opened yet on the left side, but on the right side, can you see it's absolutely nicely open. This is the Hasner's valve, which opens into the inferior meatus. Okay, so whenever you check for a patency of, suppose you have a patient with who you are planning to do a DCR, check the entire pathway of the nasolacrimal duct. So of course we have our protocol where we do syringing, we check for hard stop, soft stop. But I have also seen cases where this duct has not opened into the inferior meatus also. So in such cases, of course, when you do a DCR, it will work because you are bypassing this duct and opening the sac directly into the nasal cavity. But you may not know the cause why. So check the entire length of the duct to understand why there is a block and where there is a block. Now you can see opposite side also the Hasner's valve, it has opened nicely. Okay. So now we just come to this, we zoom into this cribriform area and we'll try to understand what we are looking at. So this plate, what you are seeing above this ethmoidal cell is actually called as the fovea ethmoidalis. But this is a misnomer. Fovea ethmoidalis is not part of the ethmoidal bone actually. It is part of the frontal bone. Okay. Why it is called fovea ethmoidalis is because imagine it's a sunny hot day and you wear a cap. Cap is not part of your body. It is an accessory. It is just the way that the frontal bone is capping the ethmoidal hair cells. That's pretty much it. Okay. So you can also see very beautifully, this is the vertical lamella, this is the horizontal lamella, and if you look at the attachment of the middle terminate, it is at this junction. This fossa, this green arrow mark which you are seeing, is called as the olfactory fossa. So you have the olfactory fibers running into this space, and that is why whenever you are mobilizing the middle terminate, always be very careful. You don't want to mobilize it very close to this lateral and medial lamellar junction for two reasons. One, you will put undue stress on the olfactory fibers and cause anosmia because you might tear those fibers. Second thing is you might also create a CSF leak. Okay, so be very careful when you are doing this. This is the MRI of the same patient where you can see that the olfactory fossa has become more prominent on the right side, and this is actually a meningoencephalocele. Majority of the times, this is the most common site for a meningoencephalocele when the patient has raised intracranial pressure. Now, what are the signs of raised intracranial pressure that you are seeing here? One, you will see an empty sella. There are 4 signs. Second one is, if we trace this backward, you will see that there is increased hyperintensity around the optic nerves. Why? Because optic nerve is actually not a nerve. It is continuation of the brain. So it is covered by all 3 layers of the dura. And whenever there is raised pressure, that is the reason why ophthalmologists will check the fundus for papilledema whenever there is a case of raised ICT, because you will see increased hyperintensity around the optic nerve on MRI. Third sign is, if you look at the medial temporal lobe, you will see that there is increased gyrations here. You see this small white specks. So that is one of the features of raised ICT. And fourth one is here you can see the empty sella. Okay, empty sella is not a constant sign. It may not always indicate to a raised ICT, but when it is present along with other features like what I explained to you, then the chance of the patient having raised ICT is on the higher side. In extreme cases or in later stages of this problem, you will see hydrocephalus also, which may or may not always be present, but that is the 5th sign. When it is present, you will obviously have the other 4 signs. Okay. Now coming back to our scan, now we focus on the middle turbinate. Middle turbinate can be pneumatized. Okay. There are 3 varieties of pneumatization, and it is important you understand what are the 3 varieties because the implications are very different. So if you look at my, the questionnaire that I use or the proforma which I use to document CT findings, you will see when we say concha bullosa is pneumatization of middle turbinate, but you have to document what is the type of concha bullosa. You have bulbous variety, lamellar variety, and extensive variety. Bulbous variety is when the lower part of the middle turbinate is pneumatized. That is called as a bulbous variety. This is the simplest variety to deal with because you just take a scissor, horizontally cut the turbinate, it will come off. So you don't have to waste your breath too much. But if you are looking, so this is the bulbous variety here. If you are looking, this is the lamellar variety. Now this and the extensive variety, if you look, where both the bulbous and the lamellar segment of the middle turbinate both are pneumatized. Now these 2 are challenges. Why? Because when you want to reduce, so if you don't reduce this part, your access to the frontal sinus becomes narrow. Okay, but at the same time, because it is pneumatized, this attachment is even more thinner than in a normal patient. So when you are trying to reduce this, preferably use a sharp instrument like a backbiter and come backwards and clip it off rather than going anti-grade, go retrograde. That will save you from damaging this middle turbinate attachment, both in the lamellar as well as the extensive variety. So these two are more challenging to deal with than the bulbous variety. So here you can start to see a horizontal structure which is appearing, that is the superior part of the uncinate process. Now the uncinate process has got three parts. You have the vertical part, intermediate part and the horizontal part. And actually if you have done a good scan, you will be able to see all three parts, where I will show you here. Now the opening of the middle meatus or the maxillary sinus, let us say, is actually in the junction between the intermediate and the horizontal segment of the uncinate process, and you'll be able to correlate that also in this scan. So there are four lamellae that we see: uncinate, Polar's modulus, ground lamella, and the Parsons ridge, which is basically the anterior wall of the sphenoid sinus. These are the four lamellae that we see. Now look at this uncinate here on the patient's left side. You can see the vertical part that has started to appear, which is then becoming the intermediate segment. Now when I cross this intermediate segment and I am going behind towards the horizontal segment, you see the opening of the maxillary sinus. This is again important because whenever you put a backbiter, it should not be in the vertical part of the uncinate. Come from the horizontal part anteriorly, then your chance of injuring the nasolacrimal duct is very, very minimal. If you start going and catching the vertical part of the uncinate, then you will see why it is a complication where you will damage the NLD. Again, another important thing is any deviation of the septum which is anterior to this maxillary sinus ostium, you have to fix it. You don't have a choice, because you might get away with surgery on the day of surgery by doing decongestion, that is fracturing the septum and everything. But in the post-operative period, just for you to enter into the sinonasal corridor will be such a massive pain that you will not be able to do it in OPD unless you put 10% spray packet and all those things, which you don't want. So if you have a practice where you are seeing 40-50 patients a day, I personally don't have the time to sit and decongest every patient. So whenever a patient walks in, I do at least 40-50 endoscopies a day. And I don't have the time to sit and decongest and all that nonsense. So I use a pediatric scope and I go straight in. And whenever I am operating on the patient, I always make it a point to stitch the middle turbinate so that I have good access, so that I don't have to struggle later on to go in or out. So that is something that you have to pay attention. So I use something called as Shaitkin's classification, where you have 4 grids. If the septal deviation is up to the medial lamella of the middle turbinate, you don't really need to do much. But the moment it crosses the medial lamella of the middle turbinate and is coming to the lateral lamella, or it is coming in the space between the lateral lamella and the lateral wall, which is grade 3, or if it is touching the lateral wall, which is grade 4, you have to operate on the septum as well. There is no option for you, because again, this is evidence based that surgeons find it difficult when you don't address this. Okay, so you can use this classification system to address the septum as well. Now pay attention at this level, that is at the level of the maxillary os. The maxillary sinus will be triangular in shape and the orbit will be exactly round in shape. Okay, it's important to document this because later on when we go backwards you'll see the changes happening. And now coming to the maxillary sinus per se, how do you know that what kind of approach I should take to deal with this pathology? That also has already been determined for you. So we have something called as the MUSC zones. Medical University of South Carolina, they did a cadaver study where they found what places are accessible and what places are not accessible depending on the approach that we take. So up to point C, A, B, C, whatever you are seeing here, whenever the disease is medial to the infraorbital nerve on your CT scan on an axial film, you don't really need to take an extended approach to the maxillary sinus. You can just do a middle meatal antrostomy and get the disease out completely. But when the disease crosses the infraorbital nerve, let us say it is going up to the posterolateral wall or involving the anterior wall, or if it is coming up to the skin. Up to the skin anyway we go for open approach. We don't really do endoscopic. I'm talking about cancers here. But let us say you have an inverted papilloma which is going all the way up to the anterior wall. In such situation, you will not be able to get away with a middle metal antrostomy, and you have to do some form of an extended approach. So medial to infraorbital nerve, MMA is enough. Lateral to infraorbital nerve when the disease is passing, you have to do an extended approach. Now this extended approach depends on what is the pathology. Suppose you have a squamous cell carcinoma, you can't say I'm going to do a prelacrimal approach. Why? Because you need to have access to look into the maxillary sinus every time the patient comes in. Every 3 months they are going to follow up with you. If you have done a prelacrimal approach, you have to do a scan every single time, which is not worth it. So you have to do a medial maxillectomy in those cases. But let us say you are dealing with a fungal polyp. You don't need to do a medial maxillectomy for a fungal polyp because it is a single time surgery. But if it is AFRS, where you want more ventilation and drainage, then again you have to do a medial maxillectomy or an extended antrostomy will be required. So these things are already decided on the CT scan itself, not on the table. Because when you start surgery, you should know what to do. Finish it off right then and there. You are not going to try things on table. Okay. So again, one of the common tumors is the inverted papilloma. The majority of the cases you have medial attachment, which is a good thing because then you can just get away with a middle metal antrostomy or a medial maxillectomy. Very rarely we see in the ethmoid, sphenoid, and frontal sinuses. So whenever you are dealing with inverted papilloma, you will have to do both CT scans as well as MRIs. CT scan will tell you the point of attachment of the inverted papilloma. So whenever you have a suspicion of IP, if you look at something like a bony projection like this, then that means that is the point of attachment of the inverted papilloma, and it also means that you have to drill it down, you have to take it. And on the MRI, you will see a convoluted or a irregular pattern on the MRI, what you are seeing there. This will definitely be seen on MRI. In fungal sinusitis in the maxilla, again, very common pathology that we find there, you will see an expansile lesion with a heterogeneous opacification. So that is the hallmark of fungal sinusitis. Okay. So there is a lot of association between vitamin D3 and AFRS. All these things we already know, and here also you can see when the disease is extending all the way anteriorly, either you make a wide antrostomy or do a medial maxillectomy because you will not be able to clear the disease completely. So we spoke about the canine fossa trephination here. I'll just show you what it looks like in this case. So this patient has allergic mucin all the way anterior, you can see, but we are not able to take it out. No matter what we do, we are not able to take it out. So then we resort to doing you can see that fungal mucin there. And this is a revision case, so we are forced to sort of clear it out completely. So we just do a sublabial canine fossa approach, and that helps you reach this area absolutely well. And this is something that you will have to plan even before, like you have to counsel the patient even before we take the patient up to surgery, not that I am deciding this on table. How do I know this? Because I have understood the MUSC zones very well. So that is how I know that you can. So once you enter this phase, then you know the entire maxillary sinus is in your control. You can either use a 0 degree or a 40 degree to achieve control over the entire maxillary sinus. You will not have any issues dealing with any kind of pathology there. So this is what the post-operative area will look like 2 years later. Now there is one thing that I want to sort of, this is a case study that I want you to sort of contribute to. So this patient presented to us with deep boring pain in the right eye for about 3 months. Okay, he's had on and off sinus problem and pain in the maxillary sinus. This is what the picture looks like. So can any of you tell me what the findings are here? And this is how I also decided to do a scan, because endoscopically there is nothing great that I could see. But when I checked his eyes, enophthalmos on which side? Patient's left side. Patient's left. Patient's right or patient's left? Patient's right. So there's just 2 findings here that you are going to see, okay? One, if you look at this scleral show here and here, there is a difference. You see this? The scleral show is more on this side when compared to this side. And the superior tarsal sulcus, you see, it's deeper when compared to this side. These are the only 2 findings based on which I did a CT scan for this patient. And you want to see what the CT scan looks like? You can see there is actually hypoglobus on this side. It is not that there was excessive scleral show on the left side. The pathology was on the right side. Of course, I had the advantage. I didn't tell you which side maxilla he had pain, but it was on the patient's right side. So the eye had gone down. There was a hypoglobus actually, and the reason for this is a imploding antrum or a silent sinus syndrome. Okay, so this is one of, we have seen a lot of these cases. So this is how it starts. Basically, this is similar to having a mid-layer retraction, which eventually becomes a plastered tympanic membrane or a grade 3, grade 4 retraction of the tympanic membrane. Same way here, the entire sinus sort of implodes. So there are certain features. What you'll see is there is fullness of the maxillary sinus there. You can see the retroantral pad of fat has become increased. You will see that the anteroposterior diameter of the maxillary sinus is reduced. If you see, there is also a hypertrophy of the turbinate on that side, and you will also see that the level of the orbit will actually be lower on the affected side when compared to the opposite side. So these are the 5 signs, and also the 6th sign is that there is, if you draw a line through the lateral, the medial orbit, it will actually be pushed more laterally up through the medial wall of the maxillary sinus. If you draw a line, because of the implosion, there is a curve in the medial wall of the maxillary sinus, which is making it push more laterally. So the entire sinus, horizontally, vertically, it has become small. That is why it's called as an imploding antrum syndrome. So we all know the pathology. It's basically an infundibular atelectasis where there is a block which causes an imploding antrum syndrome. So those are the 6 signs that you need to know. Coming to the next thing, which is around the maxillary sinus, we have the Haller cell. Haller cell is nothing but pneumatization of the roof of the maxillary sinus by the ethmoidal air cells. So if you have a large Haller cell, there is a possibility of you opening into that cell, assuming it's the maxillary sinus and not opening the real maxillary sinus on the higher side. Okay. Now coming back to the scan, you can start to appreciate this. This is the vertical lamella. I told you the same patient had a meningoencephalocele in the cribriform. You can see this, that there is increased density in the cribriform on this side when compared to the opposite side. And also pay attention to the fovea ethmoidalis here. Okay. You will see why this is important as we keep going posteriorly. Now you can also see something jutting out. I told you whenever there is a supraorbital ethmoidal cell, which we saw in this patient, the anterethmoid artery is always in a mesentery, and there is no bony covering around this anterethmoid artery also. How to know whether this is anterethmoid artery? Identify the 2 muscles, that is the superior oblique and medial rectus muscle, you will identify. If this structure is going between these 2, then it is the anterethmoid artery. And always know one thing, so the anterethmoid artery actually travels like this. So you will see the part where it is going into the olfactory fossa, because anterethmoid comes from the orbit and then it goes into the olfactory fossa. So you will see the exit before you see the entry point. Okay, so the part where it's going through the olfactory you will see before you see the exit through the orbit. So we all call this Kennedy's nipple, but he doesn't like that terminology obviously, and he's denied it vehemently in front of me multiple times. So this is what an anterethmoid artery in the mesentery looks like, and you can see if you make a cut through this part, that is the lateral part, the medial part close to the septum, you will not have a very big problem. It will just bleed, you can control that bleeding. But if you make a cut through the medial, the orbital part, then the chance of the patient having a intraorbital hemorrhage is very, very high. Another important point for you to understand is there have been cadaver studies which have found that this area of the anterethmoid artery sort of corresponds to the lowest part of the sloping part of the skull base. So be very careful in this area, because this is the lowermost part of the skull base almost, and this also corresponds roughly to the area of the basal lamella, that is the partition between the anterior and the posterior ethmoidal cells also corresponds to this segment. So we all know the Kiros classification, type 1 to 3. The higher the level of Kiros, the more the chance of you to have a CSF leak. The other thing that we all miss is the skull base asymmetry. So if you look at my form, you will also see a documentation of this. Reason being that if I...
Just for the interruption, nothing. Sorry to interrupt you actually. Just whoever, please continue. It's interesting topic going on, I don't want to interrupt. Those panelists who are there in the panel, please be there quickly. Otherwise, all the program will be disrupted. Who are there as a panelist, please go there. You see the recorded version. later on. And those of you who are interested, please come at least few of you so that you can start the program. And please continue. It's a wonderful session going on. Thank you.
Thank you.
So you can see. So you can see the divider. Now if I am putting it till here on the patient's left side, I am not going to have a complication now. But because of the skull base asymmetry, if I do it on the other side, the same level, I will be in the olfactory fossa. So documenting the skull base asymmetry again, and that is the reason why I make my fellows write this form every single time. If you do this 100 CT scans, then at the back of your mind you know what to look for. So that becomes easier for you also, and you will not miss it. So this is the basal lamella that you are seeing here. Now this is the partition between the anterior and posterior ethmoidal air cells, and beyond this you will start to see that the air cells will become bigger in size, okay, and fewer in number. As we keep going behind, I told you that at the point of the ethmoidal infundibulum, the orbit is more round in shape. See how big it was. This is the same size that I have left it from that time. See how big it was there, and now the orbit is becoming smaller in size, okay. And what was triangular, the maxillary sinus, is now becoming vertically oval because we are reaching the back end of the maxillary sinus. I told you observe the level of the maxillary sinus in relation to the floor. There it was above. Here it is below the level of the floor of the maxillary sinus. And I also told you look at the vertical lamella and the fovea ethmoidalis. This is at the same level that it was. What I've left it there at the same level. Now you can see the skull base has come lower down. And this is a very important point for everybody to understand, because the more posterior you go, the skull base starts sloping backwards. So just be careful whenever you are operating. Don't try to go at the same level. I've had a patient where iatrogenic brain injury was done because they did not register this fact. And the second mistake they made was they extended the neck, and that made them go through the skull base into the basifrontal lobe of the brain. And one of the major vessels was also injured. So be very careful to register this fact. Here you can see between the lateral wall of the orbit and roof of the maxillary sinus, you can see a gap that is appearing. That is the inferior orbital fissure. So can you see this gap here? This is the inferior orbital fissure that has started to appear. So here you can see in the anterior ethmoidal cells, there is a bit of fat between the lamina papyracea and the muscle. But look closely here. Can you see the muscle is directly on the lamina papyracea? Okay. This is an extremely important thing to remember, because all of us think that, oh, I will obviously get some fat if I injure the lamina or the periorbita, right? It's not true. In the anterior ethmoid, you will get fat. You have some amount of, margin for error. But in the posterior ethmoid, you don't have any margin for error. And that is the reason why, again, whenever you see a descent on the scan, you have to document whether it is in the anterior part, mid-segment, or it is in the posterior part, again, which we do document in our proforma. We always document that. Now that is because, see here, on the axial you can see there is so much fat between the medial rectus and the lamina. But when I go back, look at this, there is zero fat. I am directly on the muscle, and it takes, again, PJ Verma, when we had done a cadaver course together, I just told him about this interesting idea. Let us see, anyway it's a cadaver, let us just see how much time it takes with a debrider to eat the muscle in the posterior ethmoid. So we had opened the posterior ethmoid, we had left the periorbita intact, we started the timer. It is less than 2 seconds for you to eat into the medial rectus muscle. Less than 2 seconds. So this was a very interesting study where they had done, and I have seen this happen even in Bangalore. One of the surgeons actually did this mistake, and he had called me during his surgery. So interesting thing is, this is a single center study of 10 medial rectus injuries in Korea, where I was there at one point of time. So one case stands out where they have made a 21 millimeter defect. 21 millimeter matlab 2.1 centimeters in size. It's a big defect. And you obviously will think, why, if somebody has made a 2.1 centimeters, why did not he stop the minute he saw? So he failed to recognize a hypoplastic maxillary sinus. Okay. So you need to know what are the features of hypoplastic maxillary sinus. There are multiple signs. So whatever triangle shape that you are seeing, so usually in a hypoplastic maxilla it will be vertically or olive shape, it will be vertically elongated like you are seeing in this image here. Second thing is the eyeball will not be round, it will also be vertically elongated in a hypoplastic maxilla. Third thing is the floor of the maxilla will always be above the level of the nasal floor in a hypoplastic maxilla or at the same level. Fourth is that if you draw a line through the medial orbit, the orbit will actually be more medial when compared to the maxillary sinus. And if you draw a line through the mid-pupillary line, the lateral wall of the maxilla will be inside of this line. So these are the 5 signs to say that this is a hypoplastic maxilla. And you can identify this on a CT scan before. And if you don't identify it, because the orbit is vertically elongated and the maxilla is vertically shortened, you will enter the orbit. You will think that is the maxillary sinus. You will open up the entire orbit thinking it is a maxillary sinus. So coming back to our scan, now as we keep going behind, I told you skull base is sloping backwards. You can see the attachment of the middle turbinate now to the perpendicular plate of the to the middle pterygoid plate, which will start to appear shortly. And you can also start to see the appearance of the, which vessel is this? Posterior ethmoid artery. Now, you remember we saw anterethmoid artery and mesentery in the same patient. Look at the amount of bone that you have protecting the posterior ethmoid artery. It's so thick. So the posterior ethmoidal skull base is 10 times thicker than the anterethmoidal skull base. It is mainly because of the pneumatization. So you have, and this also has to do with the fact that anteriorly, our nostrils are anterior, so more air enters the anterior part of the nose, and that is why pneumatization is always more in the anterior segment when compared to posterior segment. Okay, so that is the reason why it happens. Now, which damaging anterethmoid is more dangerous or damaging posterior ethmoid is more dangerous? Which one?
Posterior.
Which one is more common? Anterior. But why is posterior more common?
Less space.
So if you look at the orbit, so it's a V-shaped structure. So posteriorly you have very little space to accumulate blood. Anteriorly you have more space. You have roughly the orbit, entire orbit is about 30 centimeters square area. So you can accumulate more blood anteriorly when compared to posteriorly. So if you injure the posterior ethmoid, I have done that in a case where we had a tumor where I was dissecting the tumor off of the posterior ethmoid and the artery got cut. Now the thing is, it retracted also into the orbit. If that happens, you have to open the orbital apex immediately, because patient will be blind almost instantaneously and you will not realize it actually. You will not have so much time to save that eyeball. Like when we say anterethmoid, now based on the latest research that has been done in rabbits, even that 90-minute mark is actually it is not true. It is actually much less than 90 minutes, because by 25 minutes itself, we start seeing that there are changes which are happening in the fundus, and this study has been done in rabbits also already. So that is the reason why even that 90-minute is a fallacy. You have to do it as soon as you identify. Whenever you injure either anterethmoid or posterior ethmoid, there is nothing like doing too much. Understand that. You have to do canthotomy, cantholysis immediately. And I would say, since you are already in the nose, do a medial, orbital decompression immediately and cut through the periorbital. It is not like you are doing too much, don't worry. It is better to do more than to do less, because once the injury happens, you will not be able to save yourself. So if this happens, that you injured the posterior ethmoid, you have to expose the orbital apex completely. Now you can start to see the infraorbital fissure is becoming more obvious to you. The optic nerve is there. Yeah, I'm almost there. So here you can also see the descending palatine vessels. You see, whenever you do an extended maxillary androstomy, you will see the descending palatine. This is how it goes through. Okay, and you can start to see the appearance of the superior orbital fissure here. Okay, Because I have been asked to keep this very basic, I'm not going to go into too much detail about the supraorbital fissure and other things, what structures pass through it, because that is more important for skull-based surgery than for routine FES. Okay, so this is the pterygopalatine fossa that you can see here below the level, behind the maxillary sinus. Observe now, the maxillary sinus is actually almost reduced to nothing. This is actually the interpterygoid or a scaphoid fossa, what we call. Okay, this is the space between the two pterygoids. And what do we see here? This is again important in angiofibromas because you will see the pterygoid venous plexus. It's a torrential bleeder actually. It bleeds like crazy whenever we do GNA. So that is one thing that you need to understand. Important thing even for PGs to know is the onod cell. So onod cell we have, either you will have the optic nerve which will be present in it, or sometimes it may be rarely absent also. And that is the supraorbital fissure, which is between the lesser wing and greater wing of the sphenoid. So that is the location of the supraorbital fissure there. That is the medial pterygoid plate and the lateral pterygoid plate. You can see two black structures here. Okay. What are these two black structures? The one which is medial, which is in the basic pterygoid, is actually the median nerve. Okay. So median nerve, if you trace it backwards, it will take you to foramen lacerum segment of the ICA. And the second one, which you are seeing here, this is called as the V2 segment of the trigeminal nerve, which is, if you trace the infraorbital nerve, it will become the V2 segment of the trigeminal. And what is this foramen called? Foramen rotundum. Okay, now this is a very important landmark because the foramen rotundum is nothing but the apex of the cavernous sinus. Cavernous sinus is an inverted pyramid structure. So if you are below the level of foramen rotundum, then you are not in a risky area. But the minute you go above the level of the foramen rotundum, that means you are in the cavernous sinus territory. For all those of you who saw the GNA video that I showed yesterday in the morning, you would have seen that I cut the infraorbital nerve before I removed the cavernous sinus segment of the GNA. So that is the reason why I did that, is because I don't want any adherence to this nerve. So that is the landmark for your cavernous sinus also. And when the mimetization happens into the base of the pterygoid between the median and the V2 segment, that is called as the lateral recess in the sphenoid. Okay, so that is the important landmark. Now you can see the septum is actually sitting on the optic nerve. So this is the intersphenoidal septum which is going and sitting on the optic nerve. Again, this is important for pituitary surgeons. The type of cellar mimetization. You have concave pre-cellar, incomplete cellar and complete cellar, where it crosses the, so whatever you are seeing in D, if it crosses the posterior margin of pituitary, that is called as a complete cellar type. And we also know about the Delano classification of the nerve. So whether it is completely covered by bone or partially covered by bone, all these things I won't, we all know it, so won't go too much into detail. So this one slide is showing you all the important structures that you need to see: the optic nerve, the supraorbital fissure, rotundum, medium canal, and the medial and lateral pterygoid plates with the interscaphoid fossa. So I'm just going to end this lecture by telling you that we all meet, and we all meet new people every day. There's a lot that I can also learn from you. It's a never-ending process. And thank you so much for giving me this wonderful opportunity. Okay.
Thank you, Gaurav, for the, I can't say it's an excellent talk, but we have learned lots from this talk. And personally, I have learned lots today also. And I request Gaurav to rush to the panel. It's already started.
Yes.
And I'm not going to waste any moment now because this radiology panel also, you can also move here. Just I can request one to Gaurav, kindly to share your this checklist.
Yeah.
And interested can take it from.
Sure.
That's a great thing. Great. Thank you so much. It was excellent. Have a good day. Bye.
Thank you.